It is just a huge honor for me today to be podcast interviewing Brian S. Gurinsky, DDS, MS. He was born in Dallas, Texas, and attended college at the University of Texas at Austin. He continued his education at Baylor College of Dentistry in Dallas, which is now Texas A&M, where he attained his Doctorate of Dental Surgery. Following graduation, Dr. Gurinsky began a 3-year residency in Periodontics and Dental Implants, on completion of which he earned his certificate in Periodontics from the University of Texas Health Science in San Antonio. Dr. Gurinsky has extensive research experience and has published and presented his findings in a number of papers and presentations. He was the lead researcher of a new soft tissue graft material utilizing amniotic tissue and is being sponsored by AstraTech to research implants in smokers. Dr. Gurinsky is the past president of the Rocky Mountain Society of Periodontics and currently serves on the executive board of the Metropolitan Dental Society as treasurer. He is consultant for the Colorado State Board of Dental Examiners. He has also been named a top dentist last 5 consecutive years and top implant surgeon by Top Dental Surgeons. Dr. Gurinsky on the editorial advisor board for 2 dental journals and is a product evaluator. He's a clinical associate professor in the Department of Surgical Dentistry at the University of Colorado School of Dental Medicine. As one of the few board-certified periodontists in Colorado, he provides a comprehensive periodontal care in a professional and caring atmosphere using the most up-to-date methods and materials. I could go on and on and on. By the way, you're new dean of the dental school.
I'm the new dean of the dental school?
No, the new dean of the dental school, Nancy, or
Denise Casabon?
Denise Casabon?
Yeah.
She was my teacher at UMKC.
All right.
She's
been dean for a few years. She was interim for a bit, and now she's been full-time for a number of years.
She is. Did you see her often?
I see her about once or twice a year. Her husband, who's a recently retired dentist, was in my study club, so I would see him all the time and hear a little bit through him.
She was so cool, man. I knew she would beat to a different drum. Even as a student, she would always answer any question from a research base.
Yeah.
I mean, you just answer like, do you think that's a cavity between 3 and 4? And she'd start quoting research. And I thought, wow, this woman is on a different level than me. But it's unbelievable. I tell everybody that when I got out of school, there's only 9 specialties. Now there are 10. But it seems like, take pediatric dentistry. The only thing that's really been hot and changing is maybe silver diamine fluoride. Endodontists. Everything seems pretty much the same specialty for the most part, except for yours, periodontics. My God, talk about an hourglass of sand just turned upside down once and then back over. It seems like when I got out of school, it was all periodontal surgery. And then that was 87. And then by 95 to 2000, people just started saying, the best way to treat this is with forceps and pliers, pull the teeth and put titanium in. And then they did that for 10 or 15 years. And now I'm back where I started, where you're back to like periodontal surgery. So it's kind of, so do you agree or disagree?
I agree. And I think you always see shifts in the pendulum. But I kind of saw this coming 10 years ago, when it seemed like everyone was wanting to jump on dental implants, and dental implants are great, we do them, but they're not fail-proof. And I think we're learning that now, that they're fraught with issues and problems and maintenance issues. And the periodontal patients that have periodontal disease don't all of a sudden get cured because you stick a hunk of titanium in them. So I'm hoping that in my specialty, we see more of a shift going back to trying to save teeth, treat things conservatively. I hope so.
You are so published. You're so accomplished. You've written so many articles for Dental Town, and they're all classics: aesthetic crown lengthening, functional osseous crown lengthening. You're just a legend. But I wanted to start with a tough question where the percentage of people who have gum disease or periodontal disease, you read stuff in the mainline press that says, 2/3 of Americans have gum disease. You see it with peri-implantitis. You see the quotes all over the board. And it's like, if someone asks you, what % of Americans have gum disease and what % of implants are failing from peri-implantitis, what would your numbers be?
Well, it depends if we include gingivitis as well. Gingivitis technically is a disease, but if you include that, you're talking 85% of the population has some form of periodontal disease. I think at least 50 to 60% is what we're hearing as true periodontitis, where bone's involved. Now, if you look at implants, I mean, maybe 9 out of 10 implants have some form of perimucositis. Maybe it hasn't affected the bone, but the numbers are maybe even more staggering than it is with periodontitis and around natural dentition.
So it's 2020. You can finally see clearly now with your 2020 vision. What has got you excited in periodontics today that wasn't there when you walked out of perio school?
It's hard. If I had to pick one thing, it would be tough. The materials are definitely changing. I think we're using some materials that I've been excited about. I started doing research about 12 years ago on an amniotic material. Initially, we were looking at using it for root coverage procedures, and then kind of morphed into a product for a membrane over bone to do more type of GTR or even GBR type stuff. And the product be just an innate, inherent product of a woman's placental tissue, amniotic tissue, has growth factors and proteins and things that are going to increase and boost the healing. And so I think we're looking along those lines. Any product that offers the body the ability to do what it wants to do, but maybe at a heightened response or a better way, as opposed to putting some inert material that isn't living or doesn't have any bioactivity. So that's one. Newer materials, products that I think help the body heal better. And then along those lines, we started doing about 8 years ago LANAP, or doing some laser procedures to help the body do what it wants to do, just like the materials we might use, trying to do things from a more minimally invasive angle, I guess you could say. So anything that we can do with less pain, less morbidity is what we should be looking at and moving in that direction. And as you mentioned, I think a lot of the fields in dentistry and things in dentistry haven't really changed all that much. I feel like what we're seeing in perio is a shift towards doing things more minimally invasive, whether it be through tissue grafting, treating periodontal disease. There's so many different new techniques, materials, modalities that I think we can be more conservative. And ultimately, patients have less pain and a faster recovery.
You just said LANAP. LANAP has a big roots in Colorado.
That's correct. Mostly because one of the top researchers, the guy that really spearheaded it, was Ray Yuckna, and Ray Yuckna's in Colorado. And so there are a lot of LANAPers here in Colorado, and what Dr. Yuckna had done in his research was kind of went against the grain for periodontics. We're so in tune to everything's got to have research. We got to see the data. We don't just jump in anything till there's histology, and we kind of go overboard. And so the periodontal community kind of turned a blind eye and poo-pooed a lot of this stuff until Dr. Yuckna's research, and he got involved. And so we were real fortunate.
When you say Yuckna, how are you saying that? Dr. what?
Dr. Ray Yuckna, Yuckna. He's kind of Yuckna. He's a kind of a legend in perio. He's been doing research with bone and synthetics forever, and he's a very well-respected, very well-known periodontist. And so we were kind of lucky to have him. He used to run the program at LSU. When the hurricanes hit, he came back to Colorado and ran the graduate program, periodontics program here, and then has just remained here and does a lot of research for Millennium.
So I want you to talk about that a little more, because when these kids are dropping $100,000 a year for dental school, a LANAP is another $100,000, a CBCT is another $100,000.
Yeah.
So since it's $100,000 investment, will you spend a little more time on it? What do you think of LANAP?
Well, it's not $100,000 anymore. That was probably about 6 years ago. I think it's closer to 130 or 140 now. I worry that it's getting priced out of the market. And if you're not going to, it's a one-trick pony really for perio. There's other lasers that do more hard tissue and soft tissue, but this laser is, which I think is the best for soft tissue, but it is just for perio. So there are a lot of general dentists that have it, but it's expensive. It's a lot of money. When I look at buying products for my office, I either think what I'm buying's got to have some type of ROI on it, or it's got to be a lot better for the patient. So when I first was in practice, the first thing I did was I bought an existing practice, but the first thing I did was I put in digital x-rays. I thought old film x-rays were it's just not what I wanted. Now, did I see a big ROI on buying digital radiography? No, but I knew it was better for my patients. In long term, maybe I started recouping that with buying less film and chemicals and all that, what have you. But that's what I have to look at when I'm buying something. Is it either going to be better for my patient, or is it something that's going to help me be more efficient and more profitable?
And where is the pendulum now between the periodontal disease treatment, where when we got out of school, I mean, you could have lower molars through furcation involvement, and they would do a hemosection, and they come back to me, and I do like 2 little premolar crowns on it, and then all that stuff just died. I mean, the first casualty of titanium implants was actually the apicoectomy retrofill. If you look at Delta Dental insurance claims, I mean that thing went extinct. And then now it's coming back. Where do you think it is now on periodontal surgery versus implants?
I think it depends. I think it depends on who you ask and what type of philosophy that person has. I'm on the extreme side, I would say, of being a conservative periodontist, where we really try to hang on to teeth. We will keep teeth that have furcation involvement and areas that I think a lot of my colleagues will take out and place implants. And we can certainly justify that through the literature on why that might be a good decision to do that. But I get a kick out of keeping teeth. It's a challenge. It's fun to keep teeth. I would like to try to keep my own teeth. So there might be areas that are kind of in the gray area, but areas that I think that we can maintain for a long period of time if the patient's motivated. So we still tunnel teeth with class 3 through and through furcations. We still do root amputations, hemisections, when I think it's called for, when I think the patient will be compliant and can maintain their teeth. Unfortunately, most of the patients that we have, they're just not that patient. I
just want to go back. There's an Institute for Advanced Laser Dentistry, and they talk a lot about fighting gum disease. And you talked about LANAP, and I wanted you to be clear, just because it's a $135,000 decision. If she was 25, she got out of dental school. She does 5 years as an associate. She's opening up her own practice. She wants to be high tech. What should she be thinking about? Whether a $135,000 LANAP laser is a good decision?
I guess it depends on what her practice demographics are. Does she see a lot of older patients? See a lot of patients with periodontal disease? I assume you're talking about a general practitioner.
Right.
I think it depends on what the patient makeup is. Is she in a new area, a young area where it's a lot of yuppies? Then maybe not. But I think if it's an older, pre-existing practice with a lot of pre-existing perio patients, then she might see some benefit. It's hard to justify. It takes a long time to recoup that amount of money. So if I was a younger dentist looking to buy technology, and I'm a GP, it wouldn't be the first one I'd rush out and get.
What would be the first one you'd rush out and get?
Oh, maybe a 3D printing machine or a CAD CAM device.
I got a theory on why those young dentists don't see a bunch of old people where they don't need LANAP. It's because I think when they're just babies, say 35 and under, they're always on Instagram and Snapchat and all this stuff, and no one 35 and under has got gum disease needs implant on Instagram, and they hate direct mail because they think it's pollution. But the people that I know crushing it in implants, they always run a dollar bill size ad that says dental implant $9.99. Because they know that all these people are coming home from the periodontist oral surgeon where the implant's like $1,250, $1,400, $1,500, and they know no one needs one implant. Everybody's coming in multiple. And the other guy I know, I mean, hell, Denture World or Affordable Dentures built their entire industry on an advertisement that says all extractions $99 because Affordable Denture says, I mean, come on, Brian, do you need a tooth extracted?
Do I need my teeth extracted?
No, do you need one tooth extracted?
I need 0 teeth extracted.
I know, same here. No one needs 1 tooth extracted. When someone comes in for that $99 extraction, they need like 6 extractions, 4 quadrants of root plane curettage. Those guys that do that $999 implant, they go, well, if you were going to place like, say, 1 implant on replacing a central incisor on a beautiful girl with a highlight, like, yeah, I need big money. But your average implant is multiple implants, especially if they're in retirement communities like Phoenix and whatever. But they say, yeah, the $99 extraction and the $999 implant, it is going to attract somebody that needs $5,000 to $50,000 worth of dental work. You know what I mean? So if you're a young girl and you're doing all your advertising on Instagram, I mean, the Instagram people aren't getting immediate. So I want you to help these young kids. They're hearing all about the oral systemic link, and my gosh, they're associating these bugs with just everything. And a lot of them say to me, every morning when I make coffee, the sun comes up. Is that a correlation? Is that a cause effect? They're saying periodontal disease, everything from Alzheimer's to whatever. Are you convinced that this gum disease, P. gingivalis, that it's are you convinced that it's the oral systemic link to anything specific?
I definitely think there's a link. The question is it a link or is there a causality in addition to that? But I think if you look at all of the different things that we're seeing a link, what do they have in common? It's all inflammatory disease. So I think periodontal disease is an inflammatory disease. I think if you look at that and you compare these diseases that are inflammatory in nature, well, I do think there's a link. And I think it's not so much the bugs that we were taught that you got to eradicate this bug and you got to eradicate that bug. I don't think that's necessarily right. I think what we need to eradicate is inflammation, whatever way we can do that. And so I think if we can eliminate inflammation or reduce inflammation instead of trying to get rid of the red complex of bugs, then I think we're better off. But I definitely think there is a link because all the links that we see from periodontal disease to other systemic diseases, they're all inflammatory in nature.
Well, now I want you to weigh in on the biggest controversy that I ever did, and that is on the great Carl Misch and his little brother Craig. And Carl would not. Carl would do smokers, and Craig wouldn't. And smoking is a huge inflammatory disease. So you learn, and she's young. She learns in dental school by the periodontist that these are the people that you don't do implants on. And one of them's smokers and all that stuff. But then in the real world, your vegan yoga instructor isn't the one that has gum disease. It's always your Uncle Charlie with a pack of cigarettes and a beer in his hand. So what do you do how do you justify the ideal and the reality?
Listen, we all got to make a living. And so if you smoke 1 cigarette a day, you're not getting an implant. The patient's either going to lie to you and tell you they're not, or you're not going to do many implants. And so what I was taught in residency was the dirty little secret is if you can get them below half a pack a day, you're probably okay. Most of the problems we saw were over half a pack a day. And then we have a frank discussion with the patient. Listen, if you smoke, you got about a 3 times higher risk that these are going to fail. They still have a high success rate, but you have a higher chance of these not taking. So I think you got to mitigate all those factors. And in Colorado, it's not just smoking cigarettes; it's the other things that people smoke here. So you got to be real specific when you say, "I had a patient today," and I said, "Hey, do you smoke?" And he goes, "No, I don't smoke. Gross." And I said, "Do you use marijuana?" "Oh, well, yeah, I do marijuana. I vape or I put it in a bong, but God, I don't smoke." I said, when I say smoking, I'm referring to anything that you put in your mouth. I'm not talking about cigarettes. And so I think most people assume you're talking just cigarettes. So we have to be specific in Colorado. But I think you've got to figure out what is your line on what you're going to treat. And we know that smokers don't heal as well. But to say that you're not going to treat anybody doing anything that smokes some, it's going to be hard to make a living.
Does you've for the international listeners, you were like this first or second state that that legalized marijuana? Wasn't it you in Oregon, or
We were first.
you were first?
Yeah.
So do you, and how many years ago was that?
Oh, I think it's going on 5 or 6 now.
So Arizona's voted it down every time, and you're our neighbor. So to international, there's a place in Arizona called Four Corners. My grandkids love it. You can put your foot down and be stepping on Arizona, New Mexico, Utah, and Colorado. But now that it's been there 5 years, did that have a material dental impact? Did you see any dental impact with your eyes after 5 years of legalized marijuana?
Not from an oral standpoint, but my office is downtown, so we see a lot of people that have come to the state and to the city because of the legalization of marijuana, people not the most savory sorts that have come here. And so we deal with that. But as far as the mouth goes, no. And when they looked at marijuana and the deleterious effects of marijuana, they found none. However, I shouldn't say one, they found one, and it was periodontal disease. That was the only correlation, was marijuana to periodontal disease. All the other things that it might do didn't show up medically.
So marijuana increases periodontal disease?
That's right.
Well, then I'm going to quit giving it to my grandchildren. I did not know that.
Depends, and it also depends on how you use it. So there's certain ways that are worse than others.
Huh. Yeah, it's interesting stuff. Tobacco was actually discovered by the Native American Indians in North America. I mean, our indigenous people figured out smoking tobacco. I wonder where they figured out to smoke marijuana. Was that also indigenous in America?
I don't know.
Huh.
I don't know.
That is interesting. Back to that oral health continuum. This is a question we get all the time in dental school. She reads this oral health continuum. She doesn't want a bunch of inflammatory. She doesn't want a bunch of inflammatory disease. All these things go bad. And there's peri-implantitis, but it's completely asymptomatic, and it's on your Uncle Bubba, and he can still go to eat a double bacon cheeseburger, and he has no pain. He loves his implant. And she's looking at, red bleeding hamburger around it. Where does she actually have research to say, I know it doesn't bother you, but this is a systemic, this is an inflammatory issue. This has got to come out and redo it. Or would you just start putting him on like 3-month maintenance and really doing the old fashioned periodontal disease?
We would. The problem is when you start losing bone. So having just the bleeding gums around it isn't the end of the world. But once we start seeing bone loss and it goes from a peri-mucositis to a peri-implantitis is when it starts to become a problem. Now, where you cut the cord and say, all right, it's got to come out, that's up to each practitioner. Some people say if you have more than a third of bone loss, you take it out. I think it depends on where in the mouth it is, and it depends on the patient and what their recall schedule's been like. But we got to treat it like periodontal disease. We have a lot of the same paradigms, even though it's different and we don't really know how to clean them adequately. We still have to use a lot of the same things we know about periodontal disease, and intervals and cleaning. We got to apply those to implants. And unfortunately, it's the same problem I have with gum disease I have with peri-implantitis. It doesn't hurt. They don't oftentimes feel a need to get treated and to undergo an expensive procedure that will hurt. So it's a tough sell.
So the Native Americans in America figured out smoking tobacco, but it was the Chinese that figured out smoking marijuana. So at least we got 1 out of 2, right? America got 1 out of 2. We're doing pretty good. So more back to periodontal implants. Again, there's 400 now dental implant companies just registered in Italy only. Just the country of Italy, with 75 million people and 50,000 dentists, has 400 implant companies because it's a big industry there. Titanium is a big industry. So many people were making titanium parts. But when you go to the clone meeting, there was like 275 implant companies. So she's 25. She wants to learn how to place implants. She ain't got time to figure out 400 different implant companies. Are you agnostic, or as a periodontist, is there an implant or certain implants that you think are special than just saying titanium is titanium is titanium?
Well, yes, my answer is yes. Do I think there's a big difference between the best one and the 50th best one? maybe not a huge difference as far as survival rates, but I have other beliefs on that. As a specialist, I'm expected to use a premium implant. So I'm using the more high-priced implants because that's what my referring base wants. They don't want me using a knockoff. But I like to use a premium implant because I know those companies are going to be around. Some of the fly-by-night companies, I don't know where they'll be in a year. I don't know if you'll be able to get restorative parts for those companies. Or if a patient goes from Denver to somewhere East Coast or West Coast that's far from here, I want to know that it's going to be easy for that patient to find a practitioner that can restore that or handle it, as opposed to wondering what the heck is this kind of implant. So do I think there's a huge difference in survivability? I don't know. But I think that long term, if there's issues, we're going to have a better chance of correcting those and working with the implant if it's a premium implant.
She doesn't know what premium implant means. She's a fourth of my listeners are still in dental school. What is a premium implant?
Well, it's one of the main companies. There's probably 4 or 5 companies that have
list the premium implant companies for her.
Straumann, Nobel Biocare.
Say it again. Straumann,
Nobel Biocare, Dentsply, Zimmer, BioHorizons. I would say those are probably the top 5, the 5 biggest. They probably have 90% of the share. And there's some other clone implants that are fine, that are good. Implant Directs of the world, those kinds of companies.
And Nobel Biocare and Implant Directs is owned by the same company, Invista.
Is that right? I know Nobel Biocare got recently bought. I thought it was Danaher, but I have no idea.
Danaher did buy it, but Danaher spun off, kind of like when we were little, Siemens owned Sirona. And then the new CEO said, we're overweight in healthcare, so he spun off Sirona, and the building didn't move. It's still right there in Austria at the same building, but it was no longer part of Siemens. And Danaher said, we're overweighted in healthcare, and they spun off the whole dental division. It's called Invista, N-V-I-S-T-A. But so you're saying the premium dental implants with Straumann, who's made a bunch of mergers and acquisitions. They bought Neodent out of Brazil. They bought others. You said Nobel Biocare, which is also Implant Direct and Vista. You said Dentsply, Zimmer 3i. What was and then the other one's BioHorizon?
BioHorizons. I would say those are the top 5. And Dentsply includes Astra and Ankylose, Freodent.
And BioHorizons now is owned by Henry Schein. They bought that. Does that change anything in your mind or not really?
Not really.
Yeah.
I still think the companies that got bought out are still doing what they do. It's the same sales force for the most part. And
so now you're a periodontist, so you said you need to use a premium dental implant. And does a general dentist need to use a premium dental implant, or would you recommend that she did?
Well, I still think for the same reasons I gave you that it's important to use a premium implant if the companies go out of business or the patient moves. But if you're
and that was because of finding replacement parts mostly and research and
yeah. But if you're a general dentist and you're looking for a more cost-effective solution, maybe you want to lower your prices below what the specialists are charging, then I think you look to consider a clone type implant that's going to be half the costs on the surgical side, and the restorative parts probably a little bit less as well. So that I would, if that were me, I would probably look at everything. Where am I going to get trained? And whoever you get trained, do they have are they teaching you on a specific implant system that you felt comfortable with? I think they all work, and the principles are all the same. It's just what's going to be around the longest.
So I know you're an intense science dude, but I know that you're aware that there's people between here, Phoenix and Colorado. I'm about what am I, a 12-hour drive from you? 12 hours, Denver to Phoenix?
I don't know. That's still too long for me.
Oh, I love that drive. I just love it. But anyway, so here's the reality of patients in between us, especially when you get around Sedona. So they say things like, if you put a gold ring on your finger, there's no there's no staining. But if you put a base metal, you know how you get that green staining around your deal. And there's just a lot of anti-metal people. and they're starting to not want any metal in their mouth. And I always ask them, do you fly metal-free airplanes? Do you drive a metal-free car? Do you have a metal-free mic? But anyway, they're crazy. But there is some dentists believe in this and pushing ceramic implants. So my question is there any evidence that out of 7.5 billion people, that some people actually indeed do have a metal allergy to these dental implants, metals? Are you interested in ceramic implants? Do you think there's a place for that? What would you say to her?
There's a place for it, and we've placed a few. The last patient I placed one on had a true allergy to titanium. We took the 4 main implants, and we knew she had allergies. We took the 4 main implants that I use. She taped them onto her arm. This is what her doctor wanted to do. She taped them onto her arm, and within an hour, she's breaking out to these. And some of the companies said, this is our ceramic implant. Straumann, for instance, says, this is our ceramic implant. Well, it does have metal in it. She taped it, still had a reaction. The only one she didn't have a reaction was one that was a pure zirconia implant that was pure ceramic implant. I'm afraid to tell you that a year and a half after we placed it, she lost that implant. But that was the only one she didn't have a true allergy to. So I've had 3 people maybe in my career that have had a true allergy to titanium. So I think there's a place for it. But I think the public hears, oh, metal's bad, or they watched, what was the Endo movie about the root problem or whatever, where they watch something like that and they get in their head that I can only have a all ceramic implant. I have to have it. So I think if the public is clamoring for something, company's going to come out with it. But I always worry about, your point, everyone's got metal everywhere, but I worry about long-term data. How are these things going to handle in 10, 12 years? And I think jury's still out on those.
Wow, that is amazing. I asked you, you said it wasn't the first thing you'd buy, and you said you wanted to buy something. So there's 3 parts to an intraoral scanner. There's a scanning, design, milling. Are you you place a lot of implants? Are you using old-fashioned impressions, polyvinyl, siloxane, polyether, Impergum, or are you starting to scan?
We've been scanning for 8 years. We use scan bodies. So if the referring dentist wants us to scan for them, we'll scan the implants, send it to the lab that they want, and they get the crown abutment in their office without having to take impressions, without having to take up chair time, buy an impression post.
What's your scanner?
iTero.
Okay, a scanner. So, it's funny because iTero is owned by Align Technology, which owns Invisalign. So people doing, Invisalign want that iTero, but you're a periodontist. Why did you pick iTero?
Well, remember I was talking earlier about what I think is better for the patient, or I have to have an ROI. It wasn't the ROI that I bought this $30,000 machine. I thought it would help boost referrals because we could do all that work on the front end. But I thought the patients would like the wow factor, and they do. They like the wow factor, not having to put all the stuff in their mouth. You show them what their impressions show up digitally, and you manipulate it, and they like that. And I kind of geek out on it too. I think it's pretty cool myself. But we could still do the same thing probably with PVS. Now, if you ask the labs, they'll tell you that they have fewer remakes with the digital impressions. But you do it a lot? No, because we don't prep crowns and we're not doing Invisalign. So I have a real small niche of when I can use it, unfortunately.
Huh. Back to that, the scanning. So you like the scanner. Are you you're designing, milling? Do you send that to well, as a periodontist, are you just placing implants, or do you actually use much lab work?
Not very much lab work, no. In these cases, we're placing the implant. We ask the referring dentist, do you want to have patient back to do traditional impressions, or would you like us to scan? And we've got some that like us to scan and some that don't. I think a lot of the referring offices perceive that it's going to cost them more in their lab bill if we scan it, which is probably the opposite. The labs have less labor; it's less labor intensive. So a lot of times those fees are less if they scan it. So the only negative is if you want them do a custom shade, and you need to use a local lab. There's fewer options for local labs they got to buy the software from iTero, which is pretty costly. So the bigger labs tend to buy it, and some of the smaller ones don't. Some of the guys that it's just kind of a mom and pop type lab, they're not investing in the software necessarily for iTero.
I asked you about LANAP, but what's really confusing to the kids in dental school, there was a dental seminar this Friday, Saturday in Phoenix, and there I saw a bunch of dental students from HE Still and Mesa and Midwestern, and a couple of different times the kids were asking me the difference between the old LANAP and the new LAPAP. So there's LANAP and LAPAP.
LAPIP.
LAPIP? LAPIP?
That's for peri-implantitis protocol.
Okay, so what's LANAP and what's LAPIP?
So LANAP generally refers to just treating teeth. So laser assisted
new attachment protocol.
New attachment protocol, thank you. And LAPIP is laser assisted peri-implantitis protocol. So LANAP.
And is it kind of the same protocol, or is it really a different protocol?
No, it's pretty much the same protocol, but there's less energy. It's a shorter procedure just because you can't have too much energy hitting the metal surface of the implant.
Another thing that they're asking about is the pinhole technique, the pinhole surgical technique. So you're a periodontist. Is that a patented special procedure, or what do you know about the pinhole technique?
I know a fair amount about it. I got to be careful what I say so I don't get documents sent to me from lawyers. But
well, it's Dentistry Uncensored, so just go for it.
All right, good. Well, I was for the last several years I was teaching a 2-day hands-on tissue grafting course for dentists. So we go through the gamut of all different techniques, all different materials. Pinhole is just one technique. There's really nothing new or revolutionary about it. It's a tunnel. We talked about tunnels decades ago, and the guy who I kind of think of as the father of perioplastic surgery, Pat Allen, who was the best at it.
What's his name?
Pat Allen out of Dallas.
Okay.
And
please tell me he wasn't a Cowboys fan.
Well, I'm a Cowboys fan. Aren't you a Cowboys fan? You're America's team.
It's funny. 4 of my 5 grandchildren are in Dallas. Are in Beeville, Texas.
Okay,
and they're all Dallas Cowboy fans. I can't get any of them to be an Arizona Cardinal. But anyway, so Pat Allen, you think he was the father of periodontal?
Well, I kind of consider him. Maybe wasn't the first, but I consider him to be the best at it. He's just an incredibly gifted surgeon, brilliant man. He was the one that really started talking about tunnels, and I was learning about that in my residency 20 years ago. And so it's not really a new technique. The difference is it's a tunnel that's the incision point is in the vestibule, and then you tunnel from up there, whereas a traditional tunnel comes through the sulcus. Traditional tunnel is actually more difficult. And then with Pinhole, instead of harvesting patient's own tissue, they're using a dissolving collagen material, really a collagen barrier cut up in strips and placed into the sulcus. So there's nothing being harvested, which makes it easy for a person doing it. And there's really, their description of it doesn't even require it being sutured. So as a periodontist, I'm not a big fan of it. I think there's very few cases that really are indicated for it. You've got to have a decent amount of keratinized tissue for it to be successful and not a real shallow sulcus, which frankly, a lot of those cases they're being done for aesthetic reasons, but not for functional reasons. So if the patient wants root coverage and they've got ample amount of keratinized tissue, they often don't need gum grafting. They just need a coronally positioned flap. And so I think there's a small indication for it, but you got to know and when to pick the right cases to do it so that it works well. So there's a lot of marketing behind it, as probably doesn't surprise you.
Okay, I've been giving this advice for 30 years, and please feel free to tell me that you completely disagree and unplug your headphones and storm out of the room. A lot of dentists, they always ask me, they always say, I need to learn a perio hygiene program. I need to learn a soft tissue management program. I bought my mom's practice, and I got these 2 old hygienists, and I'm taking all these courses on, fillings and crowns and root canals and cosmetic dentistry, and what course should I take? And I always say, well, I wouldn't take any course. I would go find the periodontist you refer to and have him come down and have a lunch and learn and give you the exact criteria. Like, okay, we're going to see these, because one of the big critiques about general dentist hygiene programs is supervised neglect. You've been seeing grandma every 3 months until you put her in a pine box and just lower her into the ground. And so I always say that it's the periodontist's fault, because, if the crown doesn't fit, it's the lab man's fault. If the hygienist does something wrong, it's the periodontist's fault. I've never done anything wrong in my entire career, but I went to the periodontist, and he does it for us. He gives my hygienist exact protocol of when you just keep doing this or when you change course and do that. And I don't have to get involved in any of the debates about arrestin and chips and should we check or refer. Is that what most periodontists will do, or is that not really what they'll do anymore?
Well, I think that's a great protocol to have. The problem is every referring dentist has their own idea of what their protocol should be. And so some offices, they don't want to refer out. And so they're going to push their hygienists to clean and scale and root plane and do things that probably need to be treated surgically. So I think it depends on who that is. If the dentist says, what's the ideal time to get it treated? I just gave a lecture a couple of days ago at our convention, and it was titled, when do I need to send to my periodontist? And we talked about this, on what the parameters are. And we've got research that tells us that we're only effective cleaning subgingivally to 3.76 millimeters. Now, that's the research. We all know that we can do better than 3.76 millimeters.
My hands are special.
Yes. and the best you're ever going to do is 6.21. That was when they spent 20 minutes on a tooth. They stained it. Then they flapped it, and they saw you only got to about 6.2. So we know we're not very good. Anything up to 6 is about as good as we're going to get. So if it's greater than 6 millimeters, it's probably going to end up needing to be treated. But the gist of my talk this weekend was you can't just treat the numbers. You got to look at everything. Is it bleeding? Do they come back every 3 months? Have they had 6 millimeter pockets for 30 years and they had surgery 31 years ago when they were 9s and 10s and they've been 5s and 6s since and haven't gotten worse? You got to look at everything. But I think every hygienist has an idea of when he or she is reaching the point of where they're not effective anymore. And every hygienist has probably a different number based on their experience level. But every dentist is going to say, keep shoving some arrestin in here or keep scaling it until you get to here, and then we have to send it out. So there's some economics behind that, I'm sure.
What about when you say when you clean subgingival, you can't see? I mean, anything subgingival is a Stevie Wonder cleaning. But now they have the perioscope. What do you think? Do you think the perioscope has changed all that, or not really?
I think the perioscope's awesome, but full disclosure, I don't have one. The perioscope is super cool. You can see what you're doing much better. Now that it takes a little time to learn how to see what you're seeing underneath it, but you're still charging surgical fees to use that. So I think it's great for cleaning. It would be nice to use that in conjunction with other things. Maybe even it'd be great to use it with one app when you're doing stuff blindly. I think it's awesome, but it's an expensive machine. There's a learning curve to using it. So are you as a dentist going to use it, or are you going to have your hygienist use it? And if it's the hygienist that's using it, are you going to train your hygienist, your center for training? And your hygienists tend to bump around from office to office. Is it a modality that you're going to keep training each hygienist you bring in every year, or however often you have to bring in a new hygienist? I mean, there's some things behind that where most dentists, I don't think, want to do it themselves. As a periodontist, we would probably use it ourselves. And I think it's a pretty awesome piece of technology, but I don't have it right now.
And she wants to learn implants, but she tells me, and I heard this weekend twice, like, God, I don't know. I mean, I want to learn to place implants, but I had $400,000 student loans. I bought a practice for $750,000. I'm thinking I'd have to get a CBCT. That's $100,000. My God, by the time you get done going to Jamaica or Dominican Republic, it's just if what would you tell somebody 4 years out of school. You know, they did their dental kindergarten. They've been out for 4 years. They got down the block, the tackle, the pass, the reception, a cleaning, a filling exam, and they're ready to start going next level. They want to learn, you know, implants. How would you coach her to start that journey?
I think, first of all, the younger dentists really should focus the first several years on being very, very, very good at bread and butter dentistry. I think too many of them are so worried about doing veneers and implants and Invisalign, and they forget making really nice crowns, doing really beautiful fillings. I think first they need to master that. After that, and they think they want to place implants, then they need to take implant courses, do hands-on courses, different continuums. Because if you're going to place implants, then you need to learn surgery. And you need to learn how to use bone grafting materials and membranes and how to suture properly. It's not just doing a flapless procedure and placing an implant. And then handling the failures when they come. You need to be comfortable doing all those things. And it's not just placing implants. It's learning how to make flaps and design your flaps. And it's more than just screwing a screw into bone. You've got to know all those other things. So I think if you're going to do that, you need to commit to understanding surgical principles first, and then finding out that dental curriculum or the continuum that fits what you want to learn.
And the news is it's really feeling with a lot of really trying to convince Americans that an electric toothbrush is going to be, I mean, there's so many. I mean, there's Quip and Sonicare and Oral-B. I mean, there's just so many of them. And now they're attaching them to an app. And, you know, I've practiced 32 years in Phoenix. I'm just trying to get my clients to not drink Mountain Dew after they smoke meth. It may be different in Denver. But the bottom line is, succinctly, is an electric toothbrush statistically significantly better than manual to prevent? It is.
It is, but the question is it better because of how the brush works? It probably is. Or is it better because it stays on for 2 minutes? So they did a study a number of years ago, and the average person, when they use a manual toothbrush, brushes for 30 seconds. So if you just brush with a regular toothbrush for 4 times as long as the average person does, so 2 minutes, would it be better? Would the electric toothbrush still be better? I don't know. Maybe, but maybe not a whole lot better. So I think most of what's better about it is it just forces you to brush for longer.
There's you know how there's these and by the way, are you agnostic to any toothbrush? I mean, I was looking at I'm trying to see what the okay, I want to show you. There's this one article out. There's Chicago Tribune had an article out, and it was comparing Get Quip, Oral-B, Burst Oral Care, Philips Sonicare. When you talk about implants, you talk about the premium dental implants. Is there a premium electric toothbrush that you think is significantly better than a standard lowest cost electric toothbrush that you get at Walmart?
I think probably the Sonicare or Oral-B are going to be the 2 best ones.
The Sonicare or the Oral-B?
Yeah, I think those are the 2 best ones. I have my personal preference, but I think those are the 2 best ones, and they're probably going to be better. But again, it goes back to if you took the cheapest battery-operated one versus a Sonicare and brushed for 2 minutes with both of them, or you did a split mouth design, you brush for 1 minute on one side with a battery-operated one and then 1 minute on the other side with a Sonicare, would you see a big difference? I don't know that you would. The companies will tell you otherwise, but I don't know that you would.
Isn't there a big electric? Isn't one of those companies in Colorado?
Waterpick, I think.
Yeah, well, Waterpick.
I think they're based out in Colorado.
Yeah, they are. Yeah, Waterpick. That was the one I was thinking. You know what Fort Collins, Colorado.
Yeah.
What I liked about the Waterpick is that, you know, when I got out of school, you told someone to get a Waterpick. If you told a man to get a Waterpick, his wife was going to smack you because he made this big mess in the bathroom. Yeah. Now there's water everywhere. And they finally made it to where you can carry it into the shower.
Yeah. I mean,
a Waterpick in the shower is perfect, but it's not a great idea in front of your mirror. So do you like Waterpick?
Yeah.
Or do you like that for cleaning?
I recommend patients get Waterpicks all the time. I'm dealing with perio patients though, so they got a lot of bleeding. They've got bigger spaces in between their teeth. I love water picks around implants if they're not used at too high of a level. I think they're great, but I also know that most people by human nature have about a couple of minutes at most that they're going to spend on their teeth. So if they give me 2 minutes, I'm going to tell them brush and floss and be done with it. If I tell you now you got to use proxy brushes, and now you got to use a water pick, and now you got to use this rinse, they're probably not going to do something. So if it's something they're not going to do, I'd rather it be probably the water pick or a rinse as opposed to brushing and flossing.
And that's water pick's owned by Church and Dwight. They bought that for $1 billion. They also own Arm & Hammer. I thought that was Arm & Hammer's funniest thing in this book is Arm & Hammer's autobiography. It starts off as, and I don't own Arm & Hammer baking soda. His entire life, every time they introduced Arm & Hammer, everybody assumed it was for his baking soda company. But Arm & Hammer owns water flosser maker Waterpik. They paid $1 billion for that. Do you think that was a good buy? And do you think, do you think that was a good deal?
I don't. It's hard to imagine $1 billion being a good deal for anything, but I guess they probably looked at the numbers more than I know. And Waterpik's coming up with newer things. They just came out with this Waterpik Fusion, where it's a toothbrush with a Waterpik built inside, and as you alluded to, they've got either a portable one or one you can take into the bathroom. So, I guess if they gave $1 billion, that sure seems like a lot of money for a one-trick pony.
Yeah. Well, the thing I was wondering about is, they got the Arm & Hammer toothpaste. They bought Waterpik, and then the New York Times comes out right after they bought this and said there was no evidence for flossing. It was basically I'm in Phoenix, Arizona. They still tease me about that. I had an 80-year-old woman put her hand on my shoulder like 2 days ago, and she goes, "I know you still say it, even though the New York Times said it's all crazy talk." What do you think about the fact that New York Times said that there was no research to show flossing? Is that actually true? And we're religious naivety?
I think it's laughable. Fine, don't floss your teeth. Get rid of all the floss. It'd be good for my business. I think it's silly. It's just kind of like the people that don't think that water fluoridation is a good thing. Maybe there haven't been the greatest design studies to prove that flossing isn't helpful. But anecdotally, I can tell when patients floss and when they don't, when they walk in immediately. So I think it's laughable that it came up and intimated that we shouldn't be flossing.
So then what about, so they bought Arm & Hammer, and they already have a toothpaste. We're talking about electric versus manual. Do you think any toothpaste are more preventive to not decay, not Streptococcus mutans, but P. gingivalis? As a periodontist, do you like some toothpaste more than other?
No. I tell them to get whatever's on sale.
Get what's on every sale. That's probably, so back to the boomer versus millennial. I always joke with the millennials. I always say, I go to, when I'm lecturing, I say, "How old are you?" And she said, "I was 25. And I said, "When I was your age, I was 28. And I said, "Are you married yet?" And she goes, "Yeah, I'm married." And I said, "Well, when I was your age, I was already divorced." But they go become a dentist about a quarter or a third of the time. Some relative, their mom, their dad. It's a very family business in dentistry. At least a quarter of everyone in dentistry has got a blood relative in there. And they're saying things to me that their old boomer dad like me does perio splints. And then she just came out of Midwestern, says there's no research for that.
For perio splints?
Yeah. Studies have shown the only real benefit for perio splints is for patient comfort.
That's true. That's what our studies have always shown, that it's only for patient comfort. Okay, I don't think they don't strengthen the teeth. They make
first of all, explain what we're talking about to the 1/4 of the kids in dental school that don't even know what we're talking about.
So we're talking about, so for those quarter of the kids who have gone through ortho, I bet a quarter of them have a bonded lingual wire in their mouth. Same kind of principle. It holds the teeth together, keeps the teeth from shifting. So if you're a perio patient and you got mobile lower teeth, then way back when we used to splint teeth, and we still splint teeth because we didn't want every time the patient would bite down on it, it would hurt. We didn't want the teeth moving. So we splint them all. I have teeth splinted all the time. And in fact, if I'm trying to regenerate bone, whether it be through a graft or a laser procedure, I know for the studies also that if there's mobility of my wound or mobility of my tooth, then I've got a much more decreased chance of that happening if there's movement. So if I can eliminate the mobility, then I know I've got a better chance of bone coming back. So there are benefits to it, but from what the studies say, yes, it's for comfort. It doesn't necessarily strengthen the teeth, but it allows sometimes a regenerative procedure to catch up and then potentially strengthen the teeth. That makes sense.
Okay, now I want to get you in a lot of trouble, and my goal here is to get your license taken away and be on the evening Denver news. There's a lot of guys like myself who, when they see an infectious mouth, the oral surgeon numbs up all four quadrants. They like to numb up all four quadrants and debride the whole mouth and do everything. And then while they're numb, I did this the other day. I had a 3-hour patient, and I numbed it all up. I'm doing the scaling, the root planing, removed 6 teeth. I mean, it was just an infectious disaster. And so the oral surgeon numbs all 4 up, and then he's in a medical dental building with 8 general dentists, and the other 7 general dentists say their whole life, well, I can't numb up all 4 quadrants, so let's just do right side, left side, because I know you won't come back for the other appointment, and I don't want my treatment plan acceptance case to be too high, so we don't do same-day dentistry, and we don't do 4-quadrant dentistry. We just design everything by intent so that nobody gets done. And I saw this lady, and she came in. She was in pain. I had the time. It was in the day. I numb up all 4 quadrants, do scaling, root planing, pull 6 teeth, all that. But anyway, long story short, United, Concordia, and dental insurance companies, they say, well, we can't pay 4 quadrants at the same time. It's like, dude, I want the United Concordia guy to go get a bypass and a quadruple, and they do 1 valve a month for 4 months. I mean, so just talk about that. Why? It just seems intuitive that if I just blow everything out of that mouth, pull out the 6 hopeless teeth that are non-restorable, let's get all the bad stuff out. Wouldn't that be better therapy than right side, left side?
Yes. And I just saw before I hopped on this call, we just did full mouth scaling and root planing. Now that said, I don't do it a whole lot, mostly because of me. In the insurance comes and says you can't do it, but for me, I don't like doing it, and I'm pooped out after I do it, and I don't know that I do as good of a job if I'm spending 4 hours doing one big procedure. But does it make sense? It makes way more sense.
But do you admit that dental insurance companies, a lot of them will not pay for that?
Yes, and that's probably what keeps us from doing it most of the time. The one that frustrates us is patient comes in and they need scaling and root planing here and maybe some here, and then the rest of their mouth's okay. So, all right, well, I'm not just going to clean 4 teeth. I'm going to still do a perio maintenance or cleaning at the same time while I've got you here, but yet they won't pay the additional amount. They'll only pay for scaling here and scaling here. And so we've got to do it for free, or you play the game where you do the perio maintenance first, and then you come back in a couple days later and do this isolated scaling root planing. It's silly that we have to play this game.
You're in Colorado, which is famous for a lot of things. I mean, they knew water fluoridation. It was brown teeth in Texas and Colorado. You had Hal Huggins, the most famous anti-amalgam guy. But some people are saying that the modern day people who are saying, and I know we talked about this earlier, that you got to get your cleanings every 3 months to prevent Alzheimer's. That's a little too Hal Huggin-y. What would you say to someone? Well, first of all, did you ever know Hal Huggins, or was that before your time?
I didn't know him personally, but I know the name for sure.
So he was the biggest anti-American. And let me just say this for the record, because I get asked this a lot about amalgam. There's a big difference between you don't like mercury, you don't like amalgam, you don't do amalgams, you don't want amalgam, versus what I never understood is the second opinions. Like, okay, he thought the amalgam should be removed out of your mouth, okay? But the case is always $25,000, $30,000. It's like, okay, how did we go from we need to get these 8 amalgams out of your mouth to 30,000. So that's why I always call bullshit, and more shit, because it was like the guys who get the TMJ things. Oh, you got TMJ, you have all this stuff. And I'm like, what? I'm not so sure. But the treatment plan was always to crown all 28 teeth. You know, it's like I bought a TMJ machine to justify the need to crown every single tooth in your head. So, you know, if you were telling me that you didn't believe in amalgam and you think they should come out, and you took out 9 MOD amalgams and replace it with 9 MOD amalgams, I'd probably believe you, because I don't want to place 9 MOD composites. I mean, the worst thing in my life is when I look at the schedule and I'm walking in the room and I have to do a quadrant of MOD composites on 2 to 6. I mean, that's just an hour of flipping work, and there's just nothing. It's just hard. But when you say you don't like amalgam, but it always translates to full mouth crown and bridge for 28 crowns, I don't trust the dentist. But some people are thinking that if you mention Alzheimer's during a 3-month recall pitch, that you're kind of crazy. What would you say to that specifically?
Well, I think it goes back to the inflammation thing. So I don't think you can draw the link and say, if you don't come in every 3 months, you're going to get Alzheimer's. No, but what you can say is that we know that people that had periodontal disease at a certain age have a higher risk factor for it, or there were more people that had it. Can't say that it causes it, but if it's me, I don't want to take a chance. I don't want to take the chance of having pancreatic cancer, ED, rheumatoid arthritis, obesity, all these other things that it's putting one more log onto the fire. So the things that I can actually affect, not my genetics, things that I can actually change my behavioral patterns, why would I not do that? So that's my attitude. I can't say that you're going to get it if you go to cleanings every 6 months as opposed to every 3 months, but I know that there's a smaller chance of it, and I have healthier mouth, which leads to potentially fewer systemic problems. Why would I not do that? What's the downside?
Last and final question. I'm trying really hard to get you in trouble. Is the probing frequency? A lot of dentists say, look, you only need an exam once a year, and these hygienists on these people on 3-month recall, why are we probing them every 3 months? But some people, it's a big debate. A lot of older people say, no, you only do an exam once a year, and we probe once a year. So the other 6-month cleaning or every 3-month cleaning, there's no probe or exam. So the question is succinctly probing frequency. And I know it's different for you because you're a periodontist in advanced cases, but what would you say to probing frequency?
Well, we don't probe every 3 months. We probe if they're getting their teeth cleaned 4 times a year, we'll probe them twice a year. And sometimes once is sufficient. I think it depends on what's their history. If they've got implants, then I want to probe more frequently than once a year so I can pick something up if it's going south. If they have a history of having advanced periodontal disease or refractory disease, I want to know regularly. I don't want to wait a year to find out if something's going on. I don't think you need to do it every 3 months. I think that's probably more than's necessary, but maybe twice a year is appropriate.
And for the record, do you have a LANAP?
I do.
You do, and you would yay or nay that LANAP? If you were a periodontist, would you yay or nay it?
I am a periodontist and I yay it.
But I mean to other periodontists. So
yeah.
I mean, there's a difference between a periodontist and a general dentist.
Yes. If I'm talking to other periodontists, I would say get it.
And what if you were talking to a general dentist?
I don't know. I think it depends on the makeup of their practice. They'd have to have a lot of perio to justify doing it. I don't know that most general dentists are going to see enough perio to justify that type of investment. The company will kill me for saying that, but I just don't know that they'll do it. They won't see enough cases.
This is my final last question. I think I'm on my 4th final last question. Just one phenomena that I never can understand is when I go out with my friends in Phoenix that are dentists, which you can just assume they're all functional alcoholics, eating cheeseburgers. It seems like for every one dentist who routinely refers for crown lengthening procedures, 4 dentists have never done it one time in their life.
Yeah.
I mean, how do you have all these guys that live in the same country, same dental school, same initials? Would you say it's about one guy does crown lengthening? Is it the 80-20 rule?
maybe the 1090 rule.
Okay, so then does that mean that it's wrong? I mean, that doesn't exist. I mean, how do 90% of dentists go their whole career without doing this, and the other 10% can't live without it? So what is it about that?
I don't know. We see a lot of teeth that have had crowns that they bleed constantly because there's a biologic width thing, and the patient just thinks it's gingivitis. Listen, the world's not going to come to an end if they don't get a crown lengthened, but yeah, so if you violate the biologic width, it may be a little more sore and it may bleed more. But I think the bigger problem is if you don't feel like you can capture that margin subgingivally through your impressions or get a good margin, then you're kind of working blindly. And if you feel like you need to see that margin, which I would, then get a crown lengthened. So you're working equigingival to the margin. Even if you don't believe in the biologic width thing at all, you got to keep that dry so you get a good impression.
And let me just give you one recommendation to the kids. A lot of times I've seen you get really, really stressed out because you just looked at the impression and you're stressed because it's not good enough. You want to re-impress, but you're running 10 minutes behind and all that kind of stuff. You know what the old guys do? You walk in this room and you say, you know what, it's too much blood and infection. I'm not even going to impress today. Let's get a temporary on this. You need to go see the periodontist. You need to blah, 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 blah. So, man, when you're mad, you're running, you're late, you got to re-impress. Actually, you don't need to re-impress. Maybe if you send it to your periodontist for a crown lengthening, then next time you get it back, there's a firm layer of pink rubber carpet and all this is gone. So your self-imposed stress, thinking it's you and your impression didn't make it, and what it is you just need to.
Yeah, I agree. I think that most dentists, they don't want that patient to have to incur that extra procedure and the extra costs, and so they bust their butt to get a better crown or a better crown margin and work in the bloody field. Make your life easier. Make it so that you're not having to deal under those circumstances and get a crown lengthened.
All right. Well, on that note, man, thank you for writing so many amazing articles on Dental Town. You're the most viewed periodontist article writer on Dental Town. I've been wanting to get you on the show for all 4 years. You're a legend in my mind and so many people's minds. Thank you so much today for spending an hour with my homies.
Hey, thanks for having me. I appreciate it. It was fun.
All right. Have a great day.